Well, hello, and welcome to another session of AFTO's Fresh Take Friday webinar series. I'm your host, Carrie Rigdon, and just in time for Thanksgiving, we are bringing back the very popular topic of hand hygiene. We're welcoming back two excellent speakers today, but first, a little housekeeping. So, as you notice, the session is being recorded, and all those who registered will receive a link to the recording as well as a copy of the slide deck in the next week. If you have any questions for our speakers, please leave them in the Q&A box below, and we'll address those during the question and answer portion of our session. We ask that you use the QA tool instead of the chat. That just makes it easier for us to see those questions. And during the Q&A session, if you'd like to ask questions verbally, feel free to use that raise hand feature at the bottom of your Zoom screen, and we'll prompt you to unmute. And lastly, I'd like to remind participants that the views and opinions expressed during this virtual event are those of the presenters and not necessarily the Association of Food and Drug Officials. Participation in this virtual event does not necessarily constitute an endorsement of the speaker's views, products, or services. Lastly, this virtual event cannot be used to train AI models. And with that, it's my pleasure to introduce our speakers. First, Jim Arbogast is a scientist with a BA in chemistry from Carleton College and a PhD in organic chemistry from UCLA. He's worked at Clorox, Dial, and Gojo, formulating consumer products, and also serving as hygiene science ambassador for Purell. With over 70 patents and over 50 publications, he studies hygiene interventions to improve infection prevention and food safety outcomes. Joining Jim is Dr. Don Schaffner, an extension specialist in food science and distinguished professor at Rutgers University, serving as department chair. His research focuses on hand washing, cross-contamination, and quantitative microbial risk assessment. A fellow of 4 professional organizations and former IAFP president from 2013 to 2014, he hosts Food Safety Talk and Risky or Not podcasts, of which I am a huge fan. Now I'd like to turn it over to Jim and Don.
Hi, everyone. Jim Arbogast here. I'm going to kick us off. This is our agenda. Just do a little bit of context setting, try to do that quickly. And then we've got 4 myths that we're going to focus on. And the reason we titled this Hand Washing Madness is there are so many myths and misinformation and bad assumptions around hand hygiene. And when I first got into hand hygiene science and product development, I was making some of those same bad assumptions. And there's actually quite a bit of science that has been done, certainly more opportunity for future applied research. But we're going to hit on these 4 myths that I think are really important. And then we'll wrap up. And if you feel like we're pushing the tempo, we are, because we're trying to leave about 15 to 20 minutes at the end, so we have time for dialogue. And happy to discuss, email you, have interactions afterwards if you want more depth on some of our points. Probably already hit on this. I should remember that but the other point I want to make is this is educational, and at the end we're going to challenge a bit about the current food code and some areas where I think there could be improvement in hand hygiene guidance there. And as I mentioned before, we're going to go top line here. I'm not going to dwell on this, but if you ever see an HH, that's hand hygiene. That kind of captures hand washing, gloving, and hand sanitizing, or alcohol-based hand rub, focused on alcohol-based hand rub. That's the global term. In the US, we tend to call it more alcohol-based hand sanitizing. So hand washing is about cleaning and removing and or killing germs if it's an antibacterial hand wash. And a hand sanitizer is all about killing germs on the hands without killing the skin. And hand sanitizer in global settings is the standard of hand hygiene in all healthcare. So the CDC and WHO both support alcohol-based hand rubs primarily, unless hands are visibly soiled. CDC changed their guidance in 2002, so 23 years ago, and WHO then issued a really comprehensive guideline in 2009. CDC has updated it in 2023. I've got the reference there at the bottom, and I'll mention that paper later. Another interesting thing we're not going to talk about today is there's no bulk soap or open refillable soap containers in healthcare. Those are not allowed. And the myths around hand sanitizers causing fire risk, those are dispelled. Those existed about 20, 30 years ago. So the current food code, I know many of you know this, and probably some of you know it better than me, the rules here, but just very concisely what FDA food code says around hand hygiene, or the key sections, I should say, is how to wash. And in there, they say wash for at least 20 seconds, rub vigorously for 10 to 15 seconds. And you can think of hand washing as maybe a 3 or 4 step process. You have to get to the sink, which takes a little bit of time, turn on the water, get the soap on your hands. Some people wet their hands first, some people don't. Scrub, and that's where I think FDA is saying 10 to 15 seconds of scrubbing. And Don's gonna talk about that. That we've got some new data to present there. When to wash, there's 9 indications. And the way I read it is it's a lot. It's basically after you touch anything, which really isn't practical in a restaurant environment or a food handling, food service type of environment. And then hand antiseptics, that's the FDA food code language. Alcohol-based hand sanitizers fall under that. They're only allowed as part of a 2-step process. So you cannot use them independently. The way the rules are written right now, you must hand wash first and then hand sanitize afterwards. Don's a co-author with John Boyce, who's a lead author on the CDC healthcare guideline of 2002. John and Don both looked really extensively into the literature around alcohol-based hand sanitizers. This is a great paper. If you haven't seen it, I would encourage you to read it, and basically concludes that there's a lot of evidence that suggests hand sanitizers would reduce risk of infection or germ transmission if your hands are not heavily soiled. Okay, then my last 2 slides, Don and I presented at the AFTO conference in Dallas earlier this year. We had a great session there, a lot of engagement, and we talked a bit about myths. We showed these myths here. So I've got a bunch here, and you'll be able to see these in the, in the afterwards in the recording or the handouts. But there was a lot of interest in the 4 myths that we presented, or the 4 myths that we chose for today. So I went pretty quick there. We're going to jump into Don, but before we do that, we've got a little survey here that we would love for you to complete. So do you disagree or agree with this statement? Hand washing for a 5-second scrub time versus a 20-second time is always less effective at germ removal. So is a short hand wash always less effective than a 20-second scrub time as currently prescribed in the food code? I'll give you about 20 to 30 seconds of awkward silence, and then we'll have some results pop up. So, interesting mix here. And over 50% are on the agree that 20 seconds is always better. So Don might counter that with some data here in a second. I'll close that. Don, off to you.
Thanks, Jim. And again, thanks to AFTO for inviting us back to talk about this topic. So what I wanted to summarize this first bit that I'm going to talk about, I'm going to briefly talk about what people actually do when you observe them in a food service setting. I want to kind of get to Jim's point there. I want to talk about how much worse is the splash and dash versus a correct hand wash, and I'll talk about what's a splash and dash and why we call it that in just a minute. I want to talk about some results from a literature review that we published quite a few years ago now, but it's still relevant. And then finally, I want to end this section on some data that was presented at ID Week and also IAFP and has now been submitted for consideration for publication in the Journal of Food Protection. Next slide, please. So Um, the food code says you have to wash, and Jim talked about the 9 instances when you have to wash. But in fact, what we know from observational data is that people really don't wash their hands, and this is from the Boyd and Schaffner paper that Jim called out earlier. And if you look over at the far right-hand column, which is boxed in red there, this is the number of times that these 4 different research teams estimated that people would have to wash their hands to remain in compliance with the code. And you can see that people would be washing their hands from 8 to almost 38 or more times per hour. And if you think about washing your hands 40 times an hour, and as Jim mentioned, the transit time to and from the sink, you would probably just be making your hands need washing and then going and washing your hands, and you'd be just sort of doing that every few minutes under some circumstances. And I think so people don't wash their hands when we think that they should, because they, in some cases, they'd be washing their hands constantly. So I don't think people are stupid, right? I think people are doing what they believe to be the right thing and doing the best they can. And again, we'll talk more about why that might or might not matter. Next slide, please. So think about that question that you just answered and take a look at the graph that's shown on the right-hand side. And I'm going to try to use some drawing tools here and see if I can't help you out. And so basically, if you look at this situation right here, under these circumstances, that splash and dash for as executed by some people is giving a greater log reduction than the appropriate hand wash. And that splash and dash, that's 5 seconds with just water and no soap. And so, yes, indeed, depending upon the person, depending upon their skin, depending upon the circumstances, there is a certain fraction of the time where one individual might do better with a splash and dash than another individual using soap and water. And so just because it doesn't comply with the food code recommendations doesn't mean that it doesn't work. The other thing that I want to just briefly call out, and I would say too, just to call out both of these figures, the figure and the table come from different manuscripts written by my graduate student, former PhD student, Dane Jensen. And this, over here on the left-hand side is just some data that Dane went and collected on his own because he was trying to figure out, well, what are we actually telling people in terms of washing? And you can see that he found 81 different hand washing signs on the internet, and basically what you can see is that they're all over the place in terms of their recommendations. So even in what we tell people, we're not consistent. So no wonder people are a little bit confused. Next slide, please. Oh, and now I see I got to erase all of these. There we go. Does that do it? Yeah, there we go. So, yeah. So this is from a 2011 literature review that I wrote, and the topic of the lit review was antimicrobial versus non-antimicrobial soaps. But what I really want to point out to you, and so basically, each of these little marks that you see on the graph is the result of a hand wash, and you can see here we summarize the literature going everywhere from looks like about 10 seconds up to 180 seconds. And of course, if the effectiveness of a hand wash was correlated with wash time, what you'd see is a very clear trend where the longer you wash, the better the hand wash is. And we just simply don't see that, right? And you can see maybe there's a little bit of an upward trend if you look at the upper end of this curve, but also mostly what I want you to pay attention to is the large spread. And so what this is saying is that when you collate all this data from the literature, let's look at 15-second hand wash, okay? You can see that you get everywhere from less than, reduction in the concentration, you get anywhere from barely any reduction at all to almost a 4-log reduction. So what this is saying is that there's a lot of variability from person to person. So, and that's probably reflective of people's personal techniques, but also the methods used to quantify hand washing. So if you look at this, what it says is that there really isn't a particularly clear trend in terms of more time leading to a more effective hand wash. Next slide, please. So now what I want to do is I want to talk about some research, like I said, that's been presented at ID Week and IAFP, and it's been submitted to Journal of Food Protection. And so what we wanted to do here was to evaluate the in vivo effectiveness of a typical foaming hand wash at 3 different wash durations, looking at not only reducing bacteria on the hands, but also preventing subsequent transfer. You can see the methods there. I won't spend any time on them, but we can talk about them more if you're interested. Next slide, please. And so what you can see here, we studied 5-second lather time, a 15-second lather time, and a 20-second lather time. What you can see, the log reduction is given in blue, and you can see that each of these situations, 5, 15, and 20 seconds, we see about a 3 log reduction in the concentration of bacteria on people's hands, as according to the methodology that we use. And you can also see that we have rather significant transfer because you have a 3 log reduction. You still have a lot of bacteria left on the hands. You can also see that the transfer to after the hand wash, the transfer is still rather significant. So we have upwards of 10 to the 5th organisms with some variability being transferred after the hand wash. So little difference looking at 5, 15, or 20 seconds. And then of course we also we looked at some other treatments, and we'll talk about those in just a minute. Next slide, please. So this is just a brief description of the core hand wash as it's used in this study, as well as the Sani Once hand wash. In the Sani Once process, you're not using soap. You're basically applying sanitizer. You are going through the 20-second protocol for washing your hands, palm to palm, front to back, claw to paw, interlock wrists and thumbs. It's basically the same that you see going on in the core hand wash on the left-hand side. The key difference being you're not using soap, you're just using sanitizer. You apply a little bit more sanitizer than you would normally use. You go through this hand washing motions, and then finally, and this is quite important, I have some data that I'm not going to present today, basically showing that actually paper towels have a physical benefit, the physical removal of bacteria. And so the Sani Once hand wash, including the paper towel, gets some benefit not only from the sanitizer, but the physical removal action of the paper towel. Next slide, please. And so this is just basically the same data that I showed you previously, looking at 5, 15, and 20 seconds. Again, about a 3 log reduction and about 10 to the 5th transferred. You can see if you just apply hand sanitizer as it's normally done, you can see you get about a 4 log reduction, so more effective than a typical hand wash, and you get reduced transfer, which is what you'd like to see. If you follow the Sani Once protocol, which is using a double dose of alcohol-based hand rub and a paper towel, you can see that you go from a 4 log reduction to a 5 log reduction. So you can see sanitizer about 1 more log effective, sanitizer with a double dose, and a paper towel about 1 more effective than that, or 2 logs more effective than simple hand wash, whether you use 5, 15, or 20 seconds. So pretty compelling data. Obviously, there's nuance and there's room for interpretation there. And again, we could talk about some of that in the Q&A if you guys are interested. With that, next slide. I think that might be it for me on this one.
It's over to me. I'm gonna pause. Great job, Don. I'm jealous of your drawing tools. I won't be doing that, but I want everyone to know that even at 5 seconds, the technique was accomplished. The subjects had to go very quickly, obviously, but there was a clinician at the contract clinical lab that did this study, and they're very experienced with this study, that made sure they got through those steps. And I audited the study, so I saw that live. And these are real hand washes, probably the leading soap that's on the market from a real dispenser. And we've got the dosing data, how much came out on the hands, and then a real hand sanitizer, alcohol-based hand sanitizer that's on the market. Okay, myth number 2 is around alcohol-based hand sanitizer. Here's the survey. Is an alcohol-based hand sanitizer always ineffective on norovirus? Do you disagree or agree with that? Or somewhere in between? Okay, this came out a little different than I expected, which is great. Maybe this isn't as much of a myth as it used to be. So over half of you are saying that hand sanitizer does have some efficacy on norovirus. I'll show you some data on that. And those of you that don't agree with that, hopefully we might sway your opinion a little bit here. So I'm going to dive in now. Gotta get control of the screen again. Sorry, there we go. So I'm going to show this slide again at the end, or this data, I should say, but this is published from a study done with Leanne Jacobs's lab at NC State. And many of you probably know that she's a real norovirus expert. She's a co-author on this study. And we looked at a variety of hand, and I'm a co-author on this study as well. We looked at a variety of hand sanitizers that are on the market currently. Those are blinded here, but they're unblinded in the paper if you're interested in that. There's products A through H, and then we ran a 60% ethanol control, just like the chart Don showed. There's a log reduction as the y-axis. So one log is 90%. And you see the ethanol control and many of the hand sanitizers came in between 1 and 2 logs. And then they're through formulation, you are able to push that up. An interesting note is that the foaming quat based hand sanitizer, which is, you see quite a bit of this on the market, that basically has zero efficacy against norovirus. So I'll tell you a little more detail on that in a minute. And I kind of jumped ahead, but the formulation does really matter to how effective you are. And I've studied this for a number of years, decades now. And in 2008, did a study with Leanne and Dr. Sitar from Canada, finger pad study, and found that some hand sanitizer formulations delivered both in vitro and in vivo activity greater than 3 logs, the 99.9%. And then we followed up, actually did some collaboration. I was kind of on the fringe of this. My former colleague, Dave Masinga, was a co-author with the CDC. Gnu Park is the lead author here, was in Jan Vinier's lab, and they also found that some of the alcohol-based hand sanitizers had efficacy against norovirus, and chlorhexidine gluconate, which is commonly used as the gold standard for hand wash active ingredient in healthcare, that was ineffective. So again, the formulation matters. And then another paper where we really dove into comparing different formulations was published in 2011 with Christine Mo's lab doing the testing. And we learned there that alcohol by itself was not the sole driver. It just kind of confirmed really that alcohol was not the driver of efficacy against human norovirus. I'm not going to get into the debate about surrogates and human norovirus, but in this testing, and we ended up going from Dr. Mo's lab to Dr. Jacobs's lab, using the ASTM E1838 test method. Earlier studies on the left here, hopefully you can see my cursor, the 2010 edition of this finger pad method, which is an ASTM method, used a vial, and you expose the test product to the virus. And this is real human norovirus in feces, so it's from field samples, and you measure the log reduction after that. They updated the method in 2017 to have a finger rubbing action, which is more, I think, representative of how a hand sanitizer is really used. And again, we found here, these are the same results from that paper, that you're, with everything we've tested, getting at least a 1 log reduction with an alcohol-based hand sanitizer. And Don's going to talk next about the hand washes. Would love to do whole hand testing. No internal, no investigational review board or safety committee, ethics committee would approve that in a controlled lab. probably would have to do a feeding study to really prove this, and it would be millions of dollars to execute that. That's why you haven't seen it. All right, my summary points. So they should give some activity. An alcohol-based hand sanitizer should give some activity. So if you're a believer in the myth that hand sanitizers don't work at all on neuro, I think that's incorrect. And I think a hand sanitizer is really practical and convenient, and that's why it got uptake in the healthcare setting. There's actually a great publication called No Time for Hand Washing, if you're interested in that, in the 1990s that looked at, it was a workflow test in hospitals, and they found that there literally just was not enough time to hand wash. So I would ask you not to exclude hand sanitizers from your thinking if you're thinking it's not efficacious against noro. All right, we're doing great on time, Don. Back to you. Here's the survey question. Soap and water hand washing is always effective on norovirus. Is soap and water always going to give a good efficacy result against human norovirus? Agree or disagree? Okay. Again, this came out a little better than I thought, so that's good. Not everyone agrees with that, but some of you do. Don, do you want to take it over?
Yeah, I think people are getting wise to our the way we're asking these questions, Jim. There's some good test takers we have here. So I'm dealing with myth number 3 here. Basically, there's several key points that I'm going to hopefully make for you in my presentation. There's very little evidence that hand washing is completely effective. And we can talk about what completely means in a little bit. The alcohol-based hand rub may work against norovirus, and in fact, some soaps may not work against norovirus. And then I do want to spend a little bit of time and talk about some really great work that FDA has done. They have published a norovirus risk assessment. That's the last link there on the slide. That's on the FDA.gov website, and that is the full risk assessment. They've also pulled out select data for publication. They published the first bit was published in the journal Risk Analysis in 2017, and then a more recent publication in 2022 in a journal Food Protection. And I'll talk a little bit about each of those studies and what some of the findings are. Next slide, please. So here is the evidence on the effectiveness of hand washing on removing various viruses. And so you can see feline calicivirus, less than a 1 log effectiveness of hand washing. And I will say too, if you begin to wade into the hand washing literature, you'll see that there's a lot of work done with what we would call surrogate organisms like feline calicivirus. And then you also see here on the slide MNV1, that's murine norovirus 1. And so until recently, relatively recently, we could not culture human norovirus. And so if you wanted to do research with human norovirus, you basically had to have a connection with somebody who collected feces from people who were sick with norovirus, because that was the only way to get norovirus, to get it from a sick person. Now we actually have a technique for culturing human norovirus. Now it's not at all easy. You have to have specialized expertise in the lab, but we're getting there. So again, let's look at the evidence here. So interestingly, a study in 2010 that was published in Applied and Environmental Microbiology, they actually used human norovirus. And what they saw here is that you see about a 0.7 to a 0.12 log reduction. If you compare that to water, water has a similar range, about 0.6 to 1.6. And so, again, you can dig into that manuscript in detail and look at the statistics. But if you look at the ranges, what that's saying is that soap is really not any more effective, at least as documented in this study, than a simple water rinse. There's also another article from Journal of Hospital Infection from 2015, again, looking at murine norovirus here. They saw a greater than 3 log reduction on this organism versus when soap was used versus a 2.8 log reduction with alcohol, with again more variability. And so it depends upon the study. You got to kind of pick your studies carefully, and depending upon what you find, what you do, you'll find different results. I would tend to trust the human norovirus work over the work with surrogates, understanding, of course, that some people just they just don't have the capacity, and so working with surrogates is all they've got. Next slide, please. So I want to talk a little bit about the FDA 2017 risk assessment. One of the really key take-home messages for me was one of the things that they looked at was, well, what if you have somebody who's sick with norovirus, but we let them stay in the facility, but we just don't let them handle any food? And what they found was that strategy doesn't really work. Because norovirus is shed in such large quantities and it can spread through cross-contamination, even if you don't have a sick worker handling food, it's going to be hard. You're going to have a hard time preventing the illness because that worker is basically shedding norovirus, which ultimately, in many cases, ends up in the food. They also looked at exclusion, and exclusion here is defined as sending the worker home until they are clear of symptoms with some post-symptom buffer period. And so what they found was that with 100% compliance with a exclusion, where the person stayed home and then they had no symptoms, after 24 hours they came back into the facility, they were able to reduce incidence of norovirus 75% of baseline. And so again, without going into excruciating detail on how they did this, we're always comparing the results against the baseline, which is 100%. So whatever 100% of illnesses looks like, this is this 100% compliance with the 24-hour buffer period. You reduce illnesses to 75% of what they would have been, so a 25% reduction, but not elimination of illness. If you have 100% compliance with a 48-hour post-symptom exclusion, then the incidence goes down to 69%. So again, you're getting less norovirus illness, but you're nowhere near what you'd like to be, which is 0%. And then also, just for comparison purposes, what if you didn't have an employee exclusion practice? Well, now you're operating at over 200% greater than baseline. So with no exclusion, you're doubling the number of people that get sick in this simulated restaurant. So the default assumption, which is 74% compliance with 24-hour exclusion, and again, that's based on some data from estimates of what we think compliance actually is. One of the things that they studied in the 2017 risk assessment was better hand washing. And I had to read the article several times to figure out what they meant by better hand washing. All they did was they just said, let's imagine that somehow people can do better, and we have a greater than one. Now we take whatever our baseline is for hand washing, and we're just going to bump it up by 1 log. So let's wave our hands, magically make hand washing 1 log better by whatever technique, whatever technology we can. Now we can see that we drop from 74% of the baseline to 62% of the baseline. So if you boost hand washing and you make it 1 log better, you get a little bit better. You move from 74 to 62, but again, you're not to 0 yet. If you bump up hand washing by some unspecified mechanism, so it's 2 logs more effective than without that magic bump, you're now at 53% of the baseline. So you've dropped the number of cases from baseline by about 50%, but certainly even making hand washing more effective doesn't result in 0 illnesses. They also looked at hand washing with gloving compliance, with fairly good gloving compliance, and you're at 58% of the baseline. Simply moving to a touchless restroom environment also allows you to move to 75% of baseline. A lot of the cross-contamination happens in the restroom, but even if you move to a touchless restroom, you're still nowhere near 0%, which is where you'd like to be. Next slide, please. And again, just briefly talking about some of the discoveries or the findings from the 2022 risk assessment. And I think this is a super important one. We kind of saw this during COVID. Everybody was freaking out and sanitizing surfaces. Didn't really work to prevent COVID, which is spread by aerosols. Same thing is true with norovirus, right? It's spread by people's hands. And so cleaning and disinfecting surfaces, while it might be a great thing to do, it really doesn't move the needle in terms of norovirus risk. Again, as I said before, restriction of working food employees, not having contact with food or food contact surfaces, not very effective in reducing norovirus. What you really need to do is to get those food workers out of the establishment and keep them out for as long as they have norovirus. And again, what if we looked at 94% exclusion? And again, in other words, they can come to work after they've been symptom-free for 24 hours. That reduced illnesses to 71% of baseline. So again, we're not at zero. We're down a little bit from the baseline, but not where we'd like to be. If you looked at 74% compliance with exclusion, which is the baseline, 100% effectiveness with gloving, hand washing compliance at 90%, which is way better than we know we actually get. Now we're able to reduce the number of consumers, sick consumers, to 43% of baseline. So a little bit more than 50%, but again, nowhere near zero yet. The best possible results that they got were to assume 90 to 100% hand washing compliance, 100% gloving compliance, 94% exclusion for 24 hours post symptoms. Now we're able to get the number of people sick down to about 20%, 19% of baseline. So again, we're still having illnesses. And again, these are some very dramatic effectiveness. Again, very high hand washing, gloving, and exclusion compliance, which we don't really tend to see in the real world. And we still don't drive the risk to zero, but we're getting it 80% of the way there. Next slide. And it's back to Jim.
Okay, the last myth we're going to hit on, here's the survey. Alcohol-based hand sanitizers always dry the skin more than soap and water hand washing. This was a hot one in Dallas when we talked about this. Quite a few questions on this one, so that's why we added that one in. Do you disagree that hand sanitizers are always more drying to the skin, or not? Okay, good. Again, over half of you are, I think, are on the right side, in my opinion, of that. You disagree. They're not always more drying, and formulation really, really impacts both of these. When people ask me at a cocktail party what's been the hardest thing to do in my career, it's been formulating a mild hand wash, as you're trying to take germs and soils off the skin without taking the good stuff in your skin down the drain. So I'm going to dive in here and power through. Okay, I had to close that. Sorry about that. All right, this is a key publication that really was a tipping point in healthcare back in the 1990s. Again, John Boyce studied skin irritation objectively of nurses. And at that point in the 90s, hand washing was the standard of care. They could not get healthcare workers to comply as well as they wanted to. And part of it was based on irritated skin. The more and more you hand wash, the more likely you are to have irritated skin. So in this study that's published here, I have the reference there in the top right. They looked at skin hydration levels through an instrument that's called a corneometer. Probably have never heard of that, or many of you haven't, but it's used in the cosmetic industry quite often. Facial, skin, and body lotions do a lot of studies with corneometers, and they looked at the hands and found that the soap and water actually drove less hydration, so the skin got drier, whereas a hand sanitizer was basically at parity. And I think they did this for a month. It was a pretty long duration. And I apologize for the eye chart here, but I think the WHO, the World Health Organization, in 2009 summarized a lot of the evidence as to why an alcohol-based hand sanitizer is less irritating, less drying to the skin. So I highlighted in yellow some key statements here. It's a key strategy. Alcohol-based hand rubs often contain humectants, which are moisturizers. They bind water. Glycerin is the most common one. And several studies have demonstrated that the hand sanitizer is actually better tolerated than soap. And I've put in green there all of those references. So a lot published on this. Got a link at the bottom to that guideline. This can be found on that section can be found on page 62. And then in the most recent guidance on hand hygiene for healthcare, which came out in 2023. This is from multiple thought leaders in the US, I think about 20 co-authors. They say that the evidence is high quality evidence that hand sanitizers in most clinical situations is superior to hand washing in preserving the hand skin integrity or the skin condition. So I did what some of you might be doing now is, hey, what does Chat GPT say about this question? So I carefully worded my question there. I'm not going to go into all of these, but they pulled up 5 references. This is an exact copy and paste. The only thing I did was put the green highlights on. Boys study that I referenced before, published in 2000. I think that was done in 1999, executed, and then published in 2000. Is called out, and then about 4 others are called out. 3 others are called out specifically, and then kind of a longitudinal study summary is the last one. So my key summary points are that modern alcohol-based hand rubs, and what I mean by that is they're formulated. Sometimes the myth of a hand sanitizer is drying to the skin might come from emergency products in the 1960s and 70s that were on ambulances, and it was basically nail polish remover. You pour that on your skin. If you did that a lot, you're not going to like your skin condition, but with moisturizing ingredients, you can overcome that and actually not damage the skin and even improve the skin in some cases. And I think another part of the reason that this is a myth is if you have cuts or cracks or even invisible damage to your skin's really dry, like it often is in the winter, and you put a hand sanitizer on, it's stinging. So a lot of people might believe, oh, that hand sanitizer is really hurting my hands. It's actually something else that's causing the hand irritation, the damaged skin. Many times in healthcare settings, that's caused by over hand washing or over gloving. Gloving can be good, but if you wear your gloves too long, that occlusion and high moisture that can occur there is damaging. And then sometimes it's a major environmental factor. Many publications on wet workers' hands, like someone who works in the fishing industry out in the ocean, or even at the sink in a restaurant, if their hands are wet a long time, they're going to damage their skin. All right, and then we just got a couple slides. I'm going to blast through these. Some recent Conference for Food Protection activity that influences the food code. Don, you're going to do the first one here, if you don't mind.
Oh, sure. Jim and I think, have a love-hate relationship with the conference and the food code. We've made many efforts over the years to remove hand wash water temperature from the code because it really isn't based on science. What we have been able to do is to take the required water temperature and lower it gradually. But I would say that FDA seems reluctant to take it out completely. My opinion is that what matters is that the hand wash sink dispense water that's comfortable. If the water is too hot, you're not going to do a good job because the water is too hot. If the water is too cold, you're not going to do a good job because the water is too cold. And so you want it to be comfortable. Where we net it out in the code is that the hand washing sink has to be capable of providing water that's at least 85 degrees Fahrenheit. So, I mean, theoretically, if you turn on the water at a hand wash sink and you measure it and it's 84, not 85, then that restaurant could be written up for that. But again, we're making progress, sort of. Jim.
Well said. And then Don, you were on Council 3 earlier this year in Denver. I co-authored, I should say, 3 different issues around hand sanitizer. This particular one, issue number 22, was presented by Stephen Lyon. He's a food safety expert from Chick-fil-A. He did a great job of presenting it. He and I co-authored that. We had a lot of input from others. And the guts of this is basically, hey, how about alcohol-based hand sanitizer be available during emergencies, hurricanes, et cetera, or in the field? And we suggested that only be allowed if that written plan, was pre-approved by local regulatory. And a lot of the Council 3 members, especially local regulators, were really in tune with this. I think they liked the fact that, in these emergency situations and hurricanes seem to be on the rise, and restaurants like Chick-fil-A and others want to be able to provide food and it's super hard to get clean water and soap out in a field environment with no plumbed water. So this passed as submitted. And then a few months later, and I've got links to these at the bottom when you get the deck, if you want to go find this and read the full thing yourself. Hopefully those links will work. They're on the foodprotection.org website, the CFP website. So that was in March, and then I think this letter was July 11th, an FDA letter, and I just pulled out the last part, highlighted it in red. This one got stopped. So it made it all the way through Council 3 and through the state voting, and then it got killed by FDA. They said FDA does not concur. There's no standard method for evaluating and comparing the effectiveness what needs to be measurably removed. They cite here soil, microbes, and chemicals. I ran into this about 10 years ago, same argument. We need a test method to compare hand sanitizers to hand washes for soil and chemical removal. I would argue that the microbes are what's making people sick. And we do have standard methods on those, and Don showed some data from that before. So they encourage they encourage researchers to develop a standard method that allows for evaluating all 3 of those aspects, which I doubt will ever happen because it's a significant amount of funding to develop that method, and researchers aren't going to just go do it on their own. So this is the last slide before we have our contact info. So this is a call to action. If you want to talk to me, especially local and state regulators, about how we might influence the food code in a positive way in 2027, through an issue or issue submissions to the CFP, I would be up for that. I think we want the hand hygiene guidance to be more evidence-based, more risk reduction focused, so risk-based interventions and guidance. And let's not live with past paradigms and past standards. This thing that, people should just hand wash more. Yeah, good luck. I've tried for 25 years, even with the right products and the right guidance, it's still a challenge, but let's get the guidance better in the food code. We've got our contact info there, went a little bit longer, but we've got at least 12 minutes for Q&A. Carrie?
Yeah. Thank you both. And oftentimes Fresh Take Friday wraps up at 10 to the hour, but we're going to extend it because we've got a lot of great questions. So if you'll permit me, I will start with the questions that are a little bit more kind of specific to the data that you have presented. So first question, Terrence had asked, what's the typical soil load on hands during these tests? And that question, Don, came through when you were discussing that first myth around slide 20 or so. So when you had the chart comparing, what was the typical soil load, if you recall?
Right, and I think this is in reference to the work that was presented at ID Week and IAFP, and it's been submitted to JFP. And so, and Jim, if you can help me out here, but I believe that in this particular case, there is no, it's just the bacteria in the growth medium that they were cultured in. But just to come back to the question and answer more generically, if you look at the published literature, there are examples where you are able to show the effectiveness even in the presence of soil on killing bacteria. So we did some research in the early 2000s by Schaffner and Schaffner, where we studied what happens if people handle deliberately contaminated frozen burger patties. So we had them do some manipulations of those burger patties. They had little particles of hamburger on their hands, but in fact, the alcohol-based hand sanitizer was effective, even in the midst of that soil. And so, but again, you have to read the literature, and it's complicated and not straightforward. But just because there's visible soil on the hands doesn't mean that it's not effective.
Great.
Yeah, and
Thanks for
that exact test method has the details. It's a light soiling. It's the broth, as Don mentioned, with the E. coli in it, and the subject presses their hands on wet paper towels with that E. coli in it. There are publications, especially from healthcare infection preventionists, where alcohol-based hand rubs still work in heavy soiling, and Don wrote that literature review. But the one I like is a study of hand washes versus hand sanitizers with blood on the hands, human blood, and bacteria in there, and you still can cut through the soil in that case. So go ahead, Carrie.
Yeah, and next questions come from Neil, who is wondering particularly about battling norovirus. Why not just use hypochlorous acid, which does have norovirus efficacy and can heal hands that have been damaged by alcohol-based hand rubs and is not flammable? Thoughts on hypochlorous acid?
Yeah, Neil, thanks for joining. I've talked with Neil before, and I meant to mention before, when I was talking about dry skin, there may be other interventions that are just as mild or even milder than a hand sanitizer. Hand washing is really hard to, affect. It really is tough on skin. So a hypochlorous acid solution, well formulated, could be good for the skin. Back to your question about efficacy, I would want to see the data on that. I would want to see the in vivo data on human hands. That finger pad method that I mentioned before, that could be done with a hypochlorous acid formulation. And to my knowledge, that hasn't been published. And as Don said, I'd rather see that with human norovirus rather than a surrogate. But even some surrogate data would be good. Don, do you want to add anything to that, or did I cover it?
No, I've got nothing else to add, Jim. I think that was good.
And sticking with hand sanitizers, so Vicky is asking, how can we trust hand sanitizers when the ones I have readily available require the hands to remain moist for several minutes? Living in a dry environment, it's nearly impossible to keep hands moist for that long for the hand sanitizer to be effective. What are your thoughts on that?
That's interesting. I've never seen an indication, fancy wording for how it should be used, and in the real world for such a high dose. In healthcare, the guidance, and there's a little bit of debate on this now, is between keeping hands wet for at least 15 to 20 seconds. One challenge they have is healthcare is some hand sanitizers say we're the cheapest and they give you about a half a milliliter, and your hands are only wet for about 5 to 10 seconds. You don't even cover your whole hands. So I believe, you should have about 1.5 milliliters of an alcohol-based hand rub, which should keep most hands wet between 20 to 30 seconds, depending on your skin condition. If you're using a product that keeps your hands wet for 1.5 to 2 minutes, that's way too much of a hand sanitizer. As long as it has at least 60% alcohol, which is the FDA rule, 60 to 95% alcohol, it's an OTC drug. You don't need that length. I'd be happy to talk to you afterwards if you want.
Yeah, thanks, Jim. And I see that we've got a hand raised.
Yeah, Amy.
Amy, would you be able to take that person off mute?
Yes. Hi, Amy. I am going to allow you to talk, and you should be able to unmute yourself and ask your question.
been an accidental hand raise.
Yeah, let us
I've
know. 'Cause
done that before.
it looks like your hand is still raised. So we'll give it a couple seconds. But then I want to go on to and Amy, if just let us know if you do have a question, perhaps in the chat. Um, this came through as more of a kind of a thought when we were talking. You two were talking about presenting all of this data. The old school glow germ activity may not be as accurate of a training on hand washing anymore. So I wanted to just ask, do we need to change how we train on hand washing? And how would we do that? What are your thoughts on that?
Yeah, I've got 2 cents to add to that. So I still think GlowGerm is a wonderful tool for teaching hand washing. I did an exercise over the summer where we had some high school kids come in, and they just loved it. Right, it was just fun for them to do, and I still think it has a place. Of course, GlowGerm is not, the particles are not bacteria. They don't behave the same as bacteria. I still think they have a use in training, and for me, they're great at training technique, right? Because what the glow germ will show you is the spots that you miss when you typically wash your hands. And so I think it's still great. Where I really think we need to move, where I would like to see us move, is in changing the code, specifically changing the when to wash occasions of the code, to allow situations, let's say if your hands are not visibly soiled, to use an alcohol-based hand sanitizer instead of a hand wash. So again, whether we'll ever get anywhere with convincing FDA of that, I don't know. But I still think the technique plays a big role. One of the big the variability you see in some of the data I presented, I think a lot of that, some of it may be due to person differences in hand and skin composition, but I think a big part of it is technique as well. And the glow germ is certainly great for teaching technique. So no, I think it's still a good teaching tool, and I'm going to keep using it.
And I totally agree with what you said. My only little addition is it's also a great way to show transmission. So sometimes you put glow germ on a doorknob at the beginning of a meeting or on one person's hands. And then after 30 minutes or an hour, use the UV light and say, wow, that really spread. It's a way of demonstrating why we're trying to do hand hygiene. We're trying to stop the spread of pathogenic microbes.
Yep, agree 100%, Jim. Thanks for calling that out.
Yep.
And I think this is a good one to wrap us up here. Based on the comments and results on individual technique, what would you suggest is the best procedure to wash hands?
Want me to start, Don, or do you want to take it?
Well,
I didn't mean to stump you. I thought this would give an opportunity to.
Again, I'll focus on, it's more like when to wash, right? I think people know, hey, like if I've got poop on my hands, that's a great time to wash your hands. If I've got raw chicken, I'm just cutting up chicken, I've got raw chicken juices on my hands, that's a great time to wash hands. And I would say in those circumstances, wash your hands until the poop is gone, or wash your hands until the chicken juice is gone. I mean, I do think maybe we don't give people enough credit, and we're just yelling at them for not doing it right. And I would much rather say, well, you probably know what to do. And of course, we can't see bacteria, so we can't rely on that. But a hand wash to remove the physical soil, and then a hand sanitizer to get what you can't see, I think that's great. But I am not a big proponent of telling people exactly that you have to do it in this specific way. I know there are others that are, but that's just not me.
I agree with your point that when to wash, key moments, as the WHO calls it, is the most important. We picked that technique, the core hand wash, for that last study because that guarantees fully covering the whole hand. So however you fully cover the whole hand with either soap or water, I don't really care. I want it to be, get that full hand covered, which means you have to use enough soap or hand sanitizer to make that feasible. And then you can, rub your hands however you want. I love the technique that we picked. It's a good one. If you feel like it's too long to memorize, you can condense that. With hand sanitizers, there's a little debate about whether you should use 6 steps or 3 steps. The data shows it doesn't matter as long as you fully cover the hand.
Excellent. Well, we've got a slew of more questions, but we have run out of time. So I encourage folks who didn't get their questions answered, please reach out to Jim and Don. With that, just in closing, I want to thank everybody for the fabulous questions. Please join us on Friday, December 5th for the next Fresh Take Friday presentation featuring Dr. Adam Kramer presenting on food safety culture in restaurants. Be on the lookout for the link to this video and a PDF version of the presentation. And finally, as we end today's session, please take a moment. You'll be prompted to complete a quick bowl before you leave the Zoom app. So please do that. That will really help us out. And thank you all. And thanks to Jim and Don, and everyone have a great day.
You're welcome, and happy
Thanks, Gary.
Thanksgiving
Thanks,
week
Jim.
next week. Thank you,
Happy
guys.
Thanksgiving.
Yeah. All right. Bye-bye.
Thanks.